Okay, so when looking to palpate the foot and ankle, you're looking for an obvious deformity. You feel crepitus, point tender or pain, swelling, and temperature change. So to start out, you have the phalanges, 1 through 5. The first phalange has a distal and proximal phalange. 2 through 5 have a distal, middle, and proximal. And then you have the head of the metatarsals, head of the first, second, third, fourth, and fifth, which leads to the shaft of the metatarsals, shaft of the first, second, third, fourth, and fifth. And then proximal to the shaft, you have the base of the metatarsals, so the base of your first, second, third, fourth, and fifth. And then at the base of your fifth metatarsal, you have your styloid process. And on the plantar side of your first, on the plantar side, below the first metatarsal head, you have your 2 sesamoid bones, which lie within a tendon. And then proximal to the base of the metatarsals, you have your navicular, and then your medial cuneiform, lateral cuneiform, medial, middle, and lateral cuneiforms. And then lateral to your last lateral cuneiform, you have your cuboid. And then your calcaneus and your talus. On the calcaneus, you have your subsentaculum tali, as well as your peroneal tubercle. And then on the posterior side of your calcaneus, you have your calcaneal tuberosity. On your talus, you have the head, which lies in here. You have the medial tubercle of the talus. And if you plantar flex and invert, you have the peroneal trochlea on the talus. Your medial and lateral malleoli. And then on your navicular, you have a navicular tuberosity. And between the subsentaculum tali and your navicular tuberosity, you have your spring ligament, which helps support the medial longitudinal arch. On your calcaneal tuberosity, you have a calcaneal bursa, which sits the most superficial to your Achilles tendon. And then deep to your Achilles tendon, you have your retrocalcaneal bursa. Moving on to ligaments. On the medial side, you have your deltoid ligament, which consists of 4. Your tibio-talar ligament, your tibial navicular ligament, your tibio-calcaneal ligament, and your posterior tibio-talar ligament. And this is your anterior tibio-talar ligament. On the lateral side, you have 3 ligaments: your posterior talofibular ligament, your calcaneofibular ligament, and your anterior talofibular ligament, which sits in the sinus tarsi right there on the lateral side. And then and then between your fibula and your tibia, you have your anterior talofibular ligament. And then moving on to the retinaculum, you have your flexor retinaculum on the medial side. You have your superior and inferior extensor retinaculum. And then on the lateral side, you have your peroneal retinaculum. On the bottom of your foot, you have your plantar fascia going from your medial tubercle of the calcaneus all the way up to your phalanges. And then moving on to muscles, you have, starting at the bottom of the foot on the plantar side, you have your flexor, no, that's wrong, not your flexor, you have your abductor hallucis, and then in the middle, you have your flexor digitorum brevis, and on the lateral side, you have your abductor digiti minimi. It's your abductor hallucis, if I said it wrong. And now muscles of the lower leg, you have your anterior compartment, which consists of your tibialis anterior and the tendon, which lies right in here if they dorsiflex. You also have your extensor digitorum longus, which runs down here, and your extensor hallucis longus, which runs right here. Also on the dorsal side of your foot, if you have them extend their toes, you have an extensor digitorum brevis, which attaches right in there. In the lateral compartment, you have your peroneal longus, which comes down around the lateral malleolus and goes under your foot. And then you have your peroneal brevis, which attaches to the styloid of the 5th metatarsal. On the posterior, you have your gastrocnemius, which is superficial and attaches at the calcaneal tuberosity. And then deep to your gastrocnemius, you have your soleus, which has the same attachment point through or via the Achilles tendon to the calcaneal tuberosity. And now in your deep posterior compartment, you have your tibialis posterior, which runs down your leg and under to your tarsals and your metatarsals. You also have your flexor hallucis longus in the deep posterior compartment and your flexor digitorum longus. Now to manual muscle test, we'll start with the anterior compartment, so have them relax. And first you're going to test the tibialis anterior, and to do so we're going to start with a concentric contraction, which means you want to shorten the muscle. So I'm going to ask them to, against my resistant, pull up toes to their nose, not nose to toes, and that's again your tibialis anterior. Your extensor hallucis longus, you're going to hold their midfoot and have, for concentric contraction, have them pull their big toe to their nose, and then again hold their midfoot for the extensor digitorum longus, and now pull their toes to their nose. And then when you're grading for these tests, it's going to be on a scale of 1 to 5, 5 being they can resist your full resistance against gravity, a 4 being minimal resistance against gravity, 3 they can only go against gravity, and then a 2 is with gravity, and 1 is no movement, indicating a rupture or other injury to that muscle, most likely a rupture. To test the lateral compartment, you're going to bring them into eversion, and we're going to do an isometric. So you're going to ask them to resist your resistance and don't let them move. Tell them not to let you move them. And then for the posterior, tibialis posterior, you're going to do an eccentric manual muscle test. So you're going to have them go into inversion, and then you're going to ask them to control your resistance as they move back to neutral. And then for your flexors, hold their midfoot, and we're going to do an eccentric contraction. So you're going to have them resist, but allow them to come back up. And then again, hold the midfoot, we'll do an isometric. So don't let me pull your toes back up. And then that is it for, nope, I forgot the superficial posterior. So for the gastrocnemius, we're gonna do a concentric contraction. So ask them to push their toes all the way down, point their toes. And that is for the gastroc. To take the gastroc out of it, you want to bend their knee, which is then shortening the upper side of their gastroc, making it relatively impossible to use the gastroc to put their toes towards the ground, push against me, and that's just their soleus then. Now, we're going to do range of motion first. Have them scoot back a little bit. And so for range of motion, we're going to use a goniometer, which I cannot say. We're first going to test active range of motion of plantar flexion, dorsiflexion. So I'm going to put the axis of the goniometer on my lateral malleolus and have the stationary arm sit right along the fibula. And you're going to put the moving arm parallel with their fifth metatarsal, and then you're going to ask them to point their toes as far as they can, keeping the stationary arm still lined up, and move the moving arm back to parallel with their fifth metatarsal. And then you're going to read that number, have them relax again, make sure you're still lined up with the fibula and at the lateral malleolus. Now ask them to bring their toes to their nose as far as they can for dorsiflexion. You're again going to line up the moving arm with their fifth metatarsal. You're going to read that number, and then you're going to have them relax. For inversion, eversion, you would have them foot prone. You would draw a line to bisect their calcaneus, and then line the stationary arm between the heads of their gastroc. The axis of the goniometer will be between their malleolus on the posterior side. And then as they move into inversion, you're going to take the moving arm to bisect their calcaneus as it moves. Read the number, bring them back to neutral, have them relax, and then do the same for eversion. So then next we're going to do special tests for the ankle. And we would start with the anterior drawer, so just have them relax as much as they can. With one hand you're going to stabilize their tib fib, and then with the other you're going to cup their calcaneus with one hand and let them relax on your forearm in slight plantar flexion, and then you're just going to pull the calcaneus forward, and you're looking for the sinus tarsi to increase, because that will increase the space and laxity compared to your other one, and that is a positive test and an implication of a sprain to the anterior talofibular ligament. Next special test, we're going to do an inversion stress test. So same hand position, cup the calcaneus just on the lateral side this time, and you're going to bring them into slight dorsiflexion, and then you're just going to move their calcaneus into inversion. This is putting stress on the lateral side of the ankle, so you're testing for a lateral ankle sprain. A positive test would be increased laxity or abnormal endpoint compared to the opposite ankle they have over there. Next would be eversion, so this time I'm going to switch my hands, have them relax. I'm going to put my left hand to stabilize their ankle or their lower leg, and then I'm going to cup just immediately on the calcaneus, and again bring them into slight dorsiflexion with your forearm, and then pull them into eversion. And this, I'm stressing the deltoid ligaments, or deltoid ligament with 4 ligaments in it, looking for abnormal endpoint or laxity compared to their other ankle, and that would be a positive sign for a medial ankle sprain. Next, we're going to do the Kliger's test, which is going to test the tibiofibular ligament, anterior tibiofibular ligament. And for this one, you're going to stabilize their lower leg and grab their midfoot, pull them into dorsiflexion, and then externally rotate their foot. A positive sign for this would be pain, either right on the spot of the ligament or going up in between your tib fib and the interosseous membrane, and that's looking again for a high ankle sprain. Next, we're going to have her scoot back just slightly, and we're going to do a fibular translation. So on this one, you're just going to have them relax, grab their fibula and try and translate posterior anteriorly. This one you're looking for hypermobility or hypomobility, as well as pain, which will indicate a sprain of the syndesmosis of the fibula. Next, while she's up here, we're going to do the Homan's test. Have her bend her knee, flex her knee, bring her into dorsiflexion, and you're just going to squeeze the calf. In this one, you're testing for pain in their calf as you squeeze, which would indicate a deep vein thrombosis. For the next test, you would have them foot prone. The Thompson test, you're testing for the Achilles tendon rupture. A positive test would be if you just squeeze their calf as they're in the prone position, you're looking for slight plantar flexion, and if there's no plantar flexion, that will indicate a rupture of the Achilles tendon. The next one, you're looking to test for tarsal tunnel syndrome. So right along the tibial nerve, you're just going to tap and looking for them to explain a burning, tingling, radiating pain, and that again be entrapment of the nerve, tarsal tunnel syndrome. Next, we're going to do neurological tests. No. Oh, we're going to test for fractures. That's also important sometimes. So you're going to, first we'll start with the squeeze test. So if you're suspecting a fracture in the distal portion of the tib or fib, you're going to start on the proximal side and you're going to squeeze the two bones together, looking for them to complain of pain where the fracture is suspected, not where you're squeezing, and that would be a positive sign for a fracture of either the tib or the fib. Another way to rule out a fracture is to have them just relax, and you're going to take the palm of your hand and you're going to bump their calcaneus 3 times, each time increasing the force that you're bumping with, and that would be a positive sign if the pain is not on the heel where you bump, but somewhere on the tib fib going up and radiating up as you bump, sending vibrations up. So then next we're going to do the neurological screening. So first we'll start with dermatomes. So we would take either sharp, dull, or 1 or 2 points and ask them to differentiate between the two with their eyes closed, as well as which leg, and we would test by picking a spot that correlates with which nerve we think is having the problem. So L4 is the medial side of the lower leg, L5 is between your first and second tarsals, S1 is the lateral side of the foot, and S2 is the calf into the hamstring. And those are your dermatomes. For myotomes, to test L4, you would do a brake test, so an isometric muscle test. Bring them into dorsiflexion and tell them to resist you and don't let me move you. For the extensor hallucis longus and L5, you're going to hold their midfoot, bring them up into extension, don't let me move your toe. For S1, you're going to bring them into eversion, and you're going to support their lower leg and say, don't let me push you in, keep them out. Good. And then for S2, have them flex their knee, tell them not to let me extend your knee. I would test your hamstring, you can do that prone as well. Reflex test for each. So for L4, you're going to do the patellar reflex. You're going to have them relax as much as they can. You're just going to find your patellar tendon. You're just going to hit it. And they should have kick out into extension with their knee. The next one is going to test L5, and it's the posterior or tibialis posterior tendon reflex. Here you're going to find it just inferior and posterior to the medial malleolus, You're just going to tap it, and you're looking for them to slightly invert their foot. I would have them flip prone then. For S1, we're going to do the Achilles tendon. So have them flip prone, just relax their leg. You're just going to tap on the Achilles tendon, and you're looking for slight plantar flexion. For the S2, have them prone again. Find the hamstring tendon lateral, so the biceps femoris tendon. You're going to place your thumb on it, and then you would tap your thumb, and you're looking for the knee to flex against you as you hold it back. And then to check for blood flow after, you could find the dorsalis pedis artery in between the first and second metatarsal. Or you could do the tibial artery, which runs again like posterior to the medial malleolus. Be right in there. And then you could also do cap refills. So you're going to press down on their toenail, and you're looking for the pink to return to their toenail within 1 to 3 seconds. If you struggle finding any of either the dorsal pulse or the tibial pulse, as well as delayed return of the pinkness, it would indicate a blood flow restriction or a vascular problem to the lower leg, to the foot at least.